Hello, my name is Jay Huang. I'm a junior attending pathologist in the United States. I go over cases almost on the daily from head to toe. If you're interested in that, consider giving a like and subscribe. Without further ado, thank you to Johns Hopkins Medicine. So this is week 811, case 2 of the unknown conference. Thank you to Dr. Rupert and Dr. Law. This is a 50-year-old male with a thyroid mass. We're going to talk about a new entity that was put in the WHO 5th edition. So what we see here from low power is distortion of the thyroid histology and architecture. We can see compressed remnants of normal thyroid histology, but it's distorted by this dominant nodule that has a solid architecture with branches of vessels. So as we look closer, we see like a solid trabecular architecture with a lot of thin vessels that resembles a papillary type architecture. Here we see more of the solid trabecular architecture of these follicles. The nuclei are larger than the red blood cells here. There's a little bit pinpoint nucleoli. There's no definitive intranuclear cytoplasmic inclusions I can see or inkies, but the nuclear atypia is present due to the nuclei being larger than the red blood cells, some pinpoint eccentric nucleoli that are present in not just one or two, but just predominantly most of them. And then we see those branch-like vessels transgressing into the tumor. Here we see some kind of architecture that reminds you of like follicular carcinoma as well, and just like overall as well, just kind of this pushing border. But it definitely has these kind of vessels. So I think this is a difficult diagnosis, and one that is even made more difficult because of this is a new diagnosis in the WHO 5th edition. Okay, let's look at the closest magnification of these cells. So these cells are they're vesicular, and they have some coarse nucleoli here with eccentric nucleoli. No inkies that we can appreciate, but there is some cellular atypia. What I did not see in this field of view definitively is necrosis or mitotic figures. But okay, so it's not medullary thyroid carcinoma. We don't see amyloid deposition. Although there are some cells with multiple nucleoli, the overall picture, this is not salt and pepper chromatin. Parathyroid carcinoma. This more resembles the follicular cells of the thyroid. So there's no remnants of chief cells and oxyphil cells, nothing like that. So this is where I was getting at this difference. So poorly differentiated thyroid carcinoma, that happens when you fulfill the Turin criteria. You need, number one, solid trabecular architecture, which we see here. Number two, you need absent PTC-like nuclear features. And I would argue that we do have some features that resemble PTC. So, but in Turin criteria for poorly differentiated thyroid carcinoma, you shouldn't have PTC-like nuclear features. Then you need at least one of three. One is any necrosis, two is 3 mites per 10 high power fields, and three is kind of like strung out nuclei look, like a wrung towel look, which I totally agree with you. It's very subjective. And a differentiated high-grade papillary thyroid carcinoma, it meets some criteria of Turin, but it has features of either PTC, like nuclear features or architectural features, as well, and or follicular carcinoma. So it is a little bit poorer prognosis than poorly differentiated thyroid carcinoma. They're related, and this is the new WHO 5th edition entity. So definitely tricky. And one I would, if I weren't sure, I would send out to a head and neck specialist. Okay, so what we were talking about was architecturally is well circumscribed, encapsulated, solid and sheet-like proliferation of atypical cells, has nested and corded architecture with some tubular structures that resemble follicles. The nuclei are grooved, clumped chromatin, and some clearing akin to PTC, and that's why the diagnosis was not poorly differentiated thyroid carcinoma, because remember, you need the lack of any PTC-like nuclear features. The high-grade architecture in combination with the nuclear features leads us to the diagnosis of differentiated high-grade papillary thyroid carcinoma. So this, as I mentioned, is the new 5th edition diagnosis. It falls under the domain of differentiated high-grade thyroid carcinomas. PTC is the most common subtype of differentiated high-grade carcinomas of the thyroid, followed by high-grade follicular and oncocytic thyroid carcinomas. The true incidence may be underestimated due to its rarity, and recent recognition is most common in the elderly and in women. The Turing criteria of classification of thyroid tumors defines poorly differentiated thyroid carcinoma, which is this one, which I have mentioned. 1, solid trabecular insular growth pattern. 2, absence of conventional PTC nuclear features. And 3, at least one of the following present: convoluted nuclei, mitotic activity greater than or equal to 3 per 10 high power field, or tumor necrosis. So in this case, there was dominant solid trabecular insular growth patterns, which fits in the Turing criteria of poorly differentiated thyroid carcinoma. However, there is PTC nuclear features, so that's why it wasn't poorly differentiated thyroid carcinoma. So that's why this is the better diagnosis. And it may have an equal or even worse prognosis than poorly differentiated thyroid carcinoma because of the presence of radioactive iodine refractory tissue present in high quantity. So parathyroid carcinoma may be differentiated from thyroid malignancy based on pre-op radiographic ultrasound assessment. In comparison to our case, parathyroid carcinoma would lack the nuclear features of PTC and be immunoreactive for parathyroid hormone, GATA3, and neuroendocrine markers, while negative for thyroid globulin and PAX8. And then just something about medullary thyroid carcinoma. It's like the melanoma of thyroids. It can mimic anything. So just always have that in the back of your differential. But again, there wasn't prominent salt and pepper chromatin, no amyloid that's made out of calcitonin. But if you weren't sure, you can get a calcitonin stain. You can get an INSM1 stain. All right. Well, thank you so much for listening in. Thank you so much for the Johns Hopkins unknown case